Hey everybody, this week we're going to be talking about mechanoreceptive pain, peripheral and central mechanisms. And I actually wanted to talk a little bit about, we've been talking so much about pain basically. I wanted to spend the week talking about what it is, but then how we can, change the perception of pain with therapies in the office. Because again, my goal with this class is to teach a little bit of the neurophysiology and then a lot of bit of the therapeutic applications and make it all clinically relevant for all of us. So understanding pain is really important. As everyone knows, we're all chiropractors. But according to the CDC, more than 50% of the US adults, 125 million, had a musculoskeletal pain disorder in 2012. I'm assuming that's probably gone up because the health of our country hasn't really gotten any better since then. More than 40% of adults with a musculoskeletal pain disorder used a complementary health approach for any reason in 2012. This was significantly higher than use among persons without a musculoskeletal pain disorder. Use of complementary health approaches for any reason among persons with neck pain or problems was more than twice as high as use among persons without these problems. So it's good. It's good to be a complementary healthcare practitioner, but we got to figure out pain mechanisms and how we can help fix people in pain. Among adults with a musculoskeletal pain disorder, use of any complementary health approach was highest among those with neck pain or problems, followed by persons with other musculoskeletal disorders. So if you look in the chart on the right, you've got arthritic conditions, low back pain, neck pain at 50.6%, and then sciatica, other musculoskeletal issues. So lots of stuff going on. The use of complementary health approaches for any reason among persons with neck pain or problems is more than twice as high as use among persons without these problems. So I know we've talked about this a bunch, but what is a mechanoreceptor? Mechanoreceptors are sensory receptors that respond to mechanical pressure or distortion. So these include the cutaneous receptors for touch, receptors that monitor muscle length and tension, so like your Golgi tendon organs, your muscle spindles, and then auditory and vestibular receptors, and then others as well. So when talking about pain, as chiropractors and complementary healthcare practitioners, I think we all know this, but it's important just to review it, the gate control theory of pain. So non-painful input will close the gates to painful input. This prevents pain sensations from traveling to the higher cortical levels. So the small diameter afferents, which is pain, will impede inhibition of pain and create pain. And the large diameter afferents, which is something like vibration, joint mechanoreceptive movement, it will excite the inhibition of pain, which is good. Excitation of inhibition leads to inhibition, so less pain. So basically, my thought behind this, and my background is in functional neurology, is if we can utilize things that can help shut down pain receptors, then we can get things working better for the patient. If we can create plasticity in those pathways, then hopefully the pain will stay away. So activation or attenuation of large diameter afferents through things like chiropractic adjustments, through things like vibration, they can shut down pain receptors, or simple things like light touch, depending on the patient's pain threshold. So this theory asserts that non-nociceptive fibers can interfere with signals from pain fibers and therefore inhibit the pain. The large diameter A beta fibers are non-nociceptive, so they don't transmit pain. And they can inhibit the effects of firing by the A delta and C, A gamma and C fibers. So again, just larger fibers will shut down the pain fibers. That's A delta. Sorry, guys. Okay. And then, of course, you get the descending regulation, which we'll go over in a second. So what's a pathway that we can use therapeutically as a target to help shut down pain and utilize that gate control theory? It's the dorsal column medial lemniscal pathway, because what it does is it will appreciate fine touch, vibration, pressure, proprioception from the opposite side of the body and fire into the contralateral cortex, crossing over in the medulla. So these will fire up those large diameter afferents, and with the hope of shutting down the smaller diameter afferents, which are your pain signals. So the utilization of peripheral mechanoreceptors to alter pain perception is something I think that we do in the office every day. And we can do it by understanding the pathways, of course, but then utilizing what I call receptor-based therapy. So again, this is a nice little diagram. On the left side, you have your ascending pain fibers, and just as a reminder, they're going to come into the contralateral side of the spinal cord. They will decussate 2 to 3 segments above the entry level, and then they'll fire up into the thalamus and then the somatosensory cortex. And then you've got the descending pathway, which we're going to speak about in a second. But you've got this area in your midbrain called your periaqueductal gray area. And this area is responsible for releasing opioids, but it really relies on good communication from the superior segments, so basically your cortex, to regulate pain and to modulate pain. So here's a good example. I'm going to go over a case study at the end of this, but I just wanted to review, the basically higher cortical functioning of movement versus synaptic movement or the lower segmental movements like a reflex. So as you guys all know that, if your brain, if it perceives something as danger, or if there's pain, if there's temperature changes that are too hot for the body, you're going to have a reflex, like a withdrawal reflex from touching those things, right? That's an important mechanism to help keep us safe. Those receptors down there in the fingertip, they have a certain threshold that must be met. Everyone's threshold is probably a little bit different. Those Tony Robbins folks, they can walk on some fire or glass or whatever they do, and then other people, they won't even go near it. And you can attenuate it by using your cortex. But anyways, once that threshold is met, there's going to be a perception of pain that fires up real quickly, and you're going to have, without even having to think about it, you're going to be able to withdraw or remove your arm or hand from danger. And the reason I wanted to go over this is because I had a cool case, and hopefully you guys have probably seen this too in your office, of a stroke patient who I was able to utilize this withdrawal reflex to actually start to stimulate movement on the hemiparetic side. So the withdrawal reflex, it's an excited afferent neuron that stimulates an excitatory interneuron that in turn will stimulate the efferent motor neurons supplying the biceps in this case, which is the area that flexes the elbow joint. Contraction of the biceps pulls the hand away from the hot stove, again without having to really think about it. The afferent neuron also stimulates inhibitory interneurons that in turn inhibit the efferent neurons supplying the triceps. So you get a really good withdrawal, right? You can't have extension if you're going to have flexion. And there's that, it's also known as reciprocal inhibition. So this type of neuronal connection involving stimulation of the nerve supply to one muscle and simultaneous inhibition of the nerves to its antagonistic muscle is known as reciprocal inhibition. Very important for coordinated movements, right? If you're trying to flex something, you can't have extension of the same limb. Same thing if you're trying to get your hand out of danger. The afferent neuron will stimulate other interneurons that carry the signal up the spinal cord to the brain via an ascending pathway. Only when the impulse reaches the sensory area of the cortex is the person aware of the pain, its location, and the type of the stimulus. Moreover, when the impulse reaches the brain, the information can be stored as memory and the person can think about what happened. So basically, stay away from that area. But it's a quick withdrawal reflex that there's really not much cognitive control over. There's just some sensation. I should say cognitive efferent motor control of. So, receptor-based therapy, and we do it every day in the office because, in my opinion, we're all chiropractors, and we're all providing some sort of sensory input by doing an adjustment. So, in the adjustments, you get activation of joint mechanoreceptors through the chiropractic adjustments that can modulate or overshadow the brain's perception of the smaller diameter fibers. Repetition of activation of joint mechanoreceptors can create positive plasticity in afferent pathways, and the positive plasticity is what can really shut down the pain. So sometimes their pain thresholds will be low, but they have pain, and you can adjust them one time, and they're like, I feel great, I never need to come back. Or some people take a few times to build that plasticity up in those afferent mechanoreceptive pathways. And again, another little chart just to talk about muscle spindles, Golgi tendon organs, and joint receptors. their structures, their locations, and their functions, which we should all know by now. So, one form of receptor-based therapy is a chiropractic adjustment. Another form of receptor-based therapy that I love utilizing in my office is vibration. And again, vibratory stimulation at specific frequencies can alter pain perception. Repetition of activation of Merkel's discs and the Meissner's corpuscles can create positive plasticity in afferent pathways, and again, the positive plasticity can shut down pain. So another chart, I know you guys all know this stuff by now, but some important things. I really like, I'm learning a lot more about frequencies and the importance of frequencies and how the brain can modulate pain with specific frequencies. Because I should provide a link to this, but if you ever read a patent of a TENS unit, it'll talk about specific frequencies that will attenuate different types of feelings. And if you can hit the nervous system at a good frequency for the patient, you can modulate pain pretty well. So low frequency vibration, 5 to 15 hertz for the mechanoreceptors, that can attenuate that stimulation. Light touch vibrations below 50 hertz, you get the Meissner's corpuscles. And then the lamellated corpuscle, the Pacinian corpuscle, which is that deep area, the deep tissue, you get deep pressure, which means a higher vibration, so about 250 hertz. So learning some hertz is pretty cool. We can get into that if you guys ever want to, and if you guys have any other information on that, I'd love to learn from you as well. So the rest of this lecture, I basically pulled different articles because this is a master's program, and I think even though we're not reading tons and tons of research, I like to tell people that we are practicing evidence-based practice every day, all day. The literature's out there, we just have to correlate it to what we're doing in the clinic. So another paper on vibration, this paper, whole body vibration training is a workplace-based sports activity for employees with chronic low back pain. Basically, everybody should be sitting on a vibrating chair to help their low back pain. But the type of device that they use in this study, it applies sinusoidal vibrations and offers continuous selectable amplitude of 0 to 5.2 millimeters depending on the foot position, and a selectable frequency of about 50 to 30 hertz, which is a kind of wide range, but everybody's a little bit different. So the whole body vibration training seems to be an effective, safe, and suitable intervention for seated working employees with chronic low back pain. Sorry about the spacing, guys. And again, I have all these papers. If anyone wants any of these papers, I have the full articles. Another one on vibration, attenuation of experimental pain by vibrotactile stimulation in patients with chronic, local, or widespread musculoskeletal pain. Homotopic vibrotactile stimulation resulted in 40% heat pain reductions in all subject groups. They also used distraction as a means to try to not have people in chronic pain. But the vibrotactile stimulation seemed to be effective and recruited analgesic mechanisms, not only in the control patients, but also the patients that had chronic musculoskeletal pain, including fibromyalgia. Light touch. In total, 44 healthy volunteers experienced heat pain, and the CT optimal, which is slow brushing, and suboptimal, which is fast brushing or vibration. These are it's crude touch or tactile touch. Slow brushing reduces heat pain in humans. So, you can use just very light touch for patients that an adjustment may be too much stimulation for them. I had a patient that was in a car accident referred to me because anytime he got an adjustment, he would actually be in more pain. And, the adjustments are great, but if you're doing a sensory input that's actually creating more pain, you could be creating what's called negative plasticity in those pathways. Those pathways become efficient, and then you get what's called the peripheral and central sensitization from what we talked about last week in the PowerPoint. So what we did with him is we just started with very light stimulation. We used, I'll go over this in a second, but we used some different acoustic frequencies with light touch on the area of pain, attenuated those areas, basically shut down pain pathways with these other pathways, and the patient started to feel better after a couple visits. So good paper there. Another one more on light touch. So this talks a little bit more about what's going on in the brain with the light touch. That's why I put this one in here. So low threshold unmyelinated mechanoafferents can modulate pain. In humans, the main brain areas that are receiving these CLTMR, which is low threshold mechanoreceptive afferents, information belong to the somatosensory system and affect processing brain networks like the contralateral posterior insular cortex or the medial prefrontal cortex. The intensity of the touch is encoded in the primary and secondary somatosensory cortex, whereas the pleasantness is encoded in the anterior cingulate gyrus, the ACC. So this type of light touch also activates regions involved in the reward processing center, which is your putamen and your orbitofrontal cortex, and in processing of social stimuli, so the posterior superior temporal sulcus. So, like a nice hug or a nice pat on the back, a nice gentle hug. It'll light up your prefrontal cortex, your orbitofrontal cortex, your somatosensory cortex. It'll also activate that anterior cingulate gyrus. And when you do that a lot, you get really good plasticity in those pathways. So just another, so we just discussed an adjustment, we discussed vibration, light touch. One thing I utilize in my office as well, kind of from a light touch standpoint, is acupressure. Not just specifically auricular acupressure, but instead of using acupuncture needles, I use acupressure. And I'm by no means super duper awesome at utilizing acupressure, but I figured out ways and different types of meridians to help people that are suffering from pain just by pressing on the acupressure points. So the efficacy of auricular acupressure for chronic low back pain, a systematic review and meta-analysis of randomized controlled trials. So it's always good to have one of those in here. In the conclusion, in summary, it is evidence that as relatively safe strategy for pain management, auricular acupressure benefits chronic low back pain. Auricular acupressure has a large effect in reducing pain within 12 weeks and at the 4-week follow-up. For the disability level, the therapeutic effect is not significant when compared with other agents. Overall, there is a pressing need for more studies on this. But just by doing auricular acupressure, you can help with low back pain. Altering the perception of pain, changing the types of fibers that are firing more consistently, shutting down those small diameter afferents, those C and A delta fibers. So the effect of low frequency sound stimulation on patients with fibromyalgia. So auricular acupressure was good. Different types of acupressure. I'm sure some of you practice acupuncture and know way more about it than I do. But this is something I'm really excited about learning is acoustic frequencies and the utilization of sound frequencies to alter brain function. So in this paper, their conclusion was the utilization of low frequency sound stimulation treatment. It showed no adverse effects, which is always good, but the patients that were receiving it, they showed statistically and clinically relevant improvement, and they're going to continue on with other trials. And if anybody speaks French, it looks like on the right, you can read it over there in French. But in this specific one, the treatments involved 23 minutes of the low frequency sound simulation at 40 hertz. This was a specific 40 hertz frequency that seemed to help the patients. And just a little bit more about the conclusion if you want to read about it, but basically it said that clinically and statistically there was some changes that were positive, and they got to do some more studies on it. But the utilization of 40 hertz in that patient. So this is a paper that actually came out a few years ago, and it's actually by a fellow chiropractor who's practices functional neurology. His name's Dave Sullivan. I believe he's somewhere in the DC area, somewhere in Virginia, I can't remember. But anyways, he had a really cool case that I just wanted to share with everybody because I just talked about auricular acupressure, acoustic frequencies, and he had a guy who had chronic migraines that just was not getting better. He worked in a factory, and he noticed that every time he stood with a fan blowing in his left ear, his migraines would start to go away. And then he'd continue work. Next day he'd come in, he'd be on a different side of the table working, and the fan would be blowing in his right ear, and he'd have really bad migraines. But every time that he was facing the side that his migraines were on were usually on the left side, whenever the fan was blowing into the same side of the pain seemed to go away. So what this chiropractor did was he did a research study on patients, and basically he used what's called an insufflation bulb on the otoscope, which was really cool. So he had this patient come in and he said, all right, how could we recreate this in a clinical setting? And I'll show you a picture of an insufflation bulb in a little bit. But what he did was he would just pulsate little tiny frequencies of air that would just stimulate the tympanic membrane, and it would shut down migraines for their patients. And these guys have actually gone on to create a device that's going through some testing, that's going to be, I think, a really great adjunct to medications if needed, chiropractic care, but some sort of adjunct for therapy for patients that are really suffering from bad migraines. I'm sure if you guys have had bad migraine patients that you can't get better, you know how difficult it can be. And this seemed to help those types of people, the people that just weren't getting better with adjustments, weren't getting better with medication. So another way to tap into the brain. But so this just showed he had 13 patients in this study, and pre-treatment all the way to 8 treatments, pretty much everybody dropped significantly, I think, except for 1 or 2 people with their head pain. I think 1 person dropped out of the study. But I've actually used this in my office in a couple of different ways. I work in an office that's connected to a birth center, so I would take a baby suction, a nose suction syringe, and I just use that to just puff some air on the tympanic membrane for any of my patients that are suffering from headaches, and it would really seem to help the headaches on the same side ear of the headache. So a great little tool to use for you guys in the clinical setting, and I'll go over a couple other things that I use in the office to help if no one's ever used them before. But this is the object on the right here. This is an insufflation bulb, and it connects right into the otoscope. There's a little hole on most Welch-Allens. And then this right here, this is your speculum, but it's got a little rubber pad, so it creates some closure of the ear. I haven't found the closure super duper necessary. That's why I could take a baby bulb syringe and just deflect the tympanic membrane and help people with that. I think he thinks differently, and I think the device that they've created will have some sort of closure there. But really cool tool to use. Just another way to shut down those sensory fibers that are firing up. And if you want a copy of that research article, he really talks a lot about the neurology behind it and how you're activating cranial nerve 8, which is firing into the pontine centers, and the pontine centers are activating all different sorts of vagal nuclei and things that are just going to help put you in more of a parasympathetic state, and obviously all the larger fibers that are bigger than the pain fibers, shutting those pain fibers down. So great little tool to have. I use that in the office. Again, if you have any questions about that, please let me know. We could start a discussion about it. But a good thing to remember, everything peripheral has a central consequence. I say this all the time, if anyone has an injury that's peripheral in nature, the brain is going to be affected, and the brain tissue is prime real estate. So if you don't use it, or if it's been affected, you're going to lose it, and something else is going to take over. So here's a couple of papers just kind of reinforcing that statement. The comparison of cortical activation patterns by active exercise, proprioceptive input, and touch stimulation in the human brain, a functional MRI study. So here it just shows that doing different types of exercises, having proprioceptive input, receiving touch stimulation, you're going to light up areas of the brain. The areas that are, whatever areas of the body are receiving that are going to light up in the brain. So, everything we're doing peripherally is having a central consequence. We're sensory beings. We rely on good sensory input from the environment. Differences in gray matter volume in patients with Crohn's disease with and without abdominal pain. So this was a cool paper. These results suggest that differences exist in the brain volume between these were celiac disease patients in remission with and without abdominal pain. The negative correlation of the GM volumes in the insular and the anterior cingulate gyrus and the presence and severity of abdominal pain and celiac disease suggests these structures are closely related to visceral pain processing. So basically, the areas of the brain that started to change were thought to be very much associated with the areas that are responsible for what's called interoceptive processing, which if you read about interoceptive processing, the insular cortex and the anterior cingulate gyrus are highly responsible for that. And all that term means is your brain's awareness of where the internal environment is, so your guts, everything like that. Keeping pain out of mind, the role of the dorsolateral prefrontal cortex in pain modulation. The CNS is capable of altering sensitivity to painful stimuli. Endogenous pain inhibition is believed to account for the considerable fluctuation of pain that occurs over very short periods of time. The biological significance of endogenous pain control is generally seen in the context of behavioral conflicts in which the individual needs to disengage from pain in order to fight or escape the presence of the body injury. A likely candidate brain area to coordinate pain modulation with goal-directed behavior obviously would be the frontal lobe. Evidence suggests that the dorsolateral prefrontal cortex, comprising of the Brodmann areas 9 and 46, is important for continuous monitoring of the external world, which is different from what we just talked about, the insular cortex and the anterior cingulate gyrus, maintenance of information in short-term memory, and governing efficient performance control in the presence of interfering stimuli. And then one more on this, I believe, the cerebral cortex modulation of pain. So recent studies have shown that the ACC, the insular cortex, the primary and secondary somatosensory cortices, the ventrolateral orbital cortex, and the motor cortex are all involved in pain modulation. I'll go on to say that also the cerebellum is. But these cortical structures constitute, respectively, the medial and lateral pain systems, the nucleus submedius, the VLO, PAG system, and the motor cortex system. Multiple neurotransmitters, including, which we'll get into in another lecture, opioid, glutamate, GABA, dopamine transmitters are involved in modulation of pain by these cortical structures. So a good paper there. And again, if you guys want any of these papers, please let me know, and I'll share with you the full paper. So I had an interesting case come in. This gentleman, he's a 47-year-old male that suffered a left CVA in October of 2017. And it was a pretty bad stroke. I thought this was a cool image just to show some stuff, but he hasn't moved the right side of his body since the accident. He really hasn't. After he was intubated in the ICU, he came to. He was in kind of a. They said he wasn't in a coma, but in a very delirious state. And after that, he went to a really, really great spinal cord brain injury rehab center here in Atlanta, and he was making improvement, but he still hadn't moved the right side of his body. Basically, he was kind of just becoming more alert, more oriented to self, and getting up and not getting up, but just moving around a little bit in his chair. And then after that, he went to a care facility where he really started to not do too well. He just started to regress a little bit. Any of the function that he gained in the 7 weeks that he was at this really great rehab center, he had lost there. So by the time I had seen him, he really hadn't done much physical therapy, any occupational therapy. The insurance ran out. So unfortunately, he really hasn't been using it. And we know that if you don't use it, you lose it. And if you lose it and you don't lose it, if you lose it and you don't use it, you're going to continue to lose what you lost. So unfortunately for him, he just really hadn't moved the right side of his body at all. So he really wanted to get back to it. He's a father of two. His son is going into the NFL and plays football at a great college, so he wants to attend the games, and we want him to attend too. So some of the issues that you see with a left CVA, paralyzed right side, obviously, impaired speech and language, because the majority of people's speech centers is on the left. You got Wernicke's and Broca's. Broca's more in the frontal lobe. Wernicke's more in the parietotemporal occipital area. But slow performance, visual field defects, which he didn't seem to have. I believe he had a little bit, but nothing that was diagnosed, and he did okay with some of my testing there. Aware of his deficits. He is very aware. He wasn't really depressed, but just a little bit, not very excited about what's going on. Impaired comprehension. So smart guy, but had a lot of difficulty doing, well, I'll go on the next page. He had a lot of difficulty doing simple math. He had some dysarthria. Obviously, the speech centers are on the left side of the body. He had some difficulty with the math, like I said, altered pain perception, and he was flaccid on the right upper extremity and right lower extremity. He had some flexor dominance tone, but for the majority, like any movement, he was very flaccid. Here's a really great image I just found on the internet. I thought you guys would like it. I'll just throw it in here. just looking at how the mind processes pain. So that's why I wanted to talk about this case, because I'll show you this video here in a second, but they said that he couldn't move anything, so I tested his reflexes. Obviously, he had some clonus in the right of his right ankle, but I actually I was starting to use different types of sensory input to see how we could just change the brain's awareness of where his body was in space. Because I always tell people, especially stroke patients, if your brain doesn't know where your body is in space, how can it do any efficient movement whatsoever? So for me, with a stroke patient, the first thing is really just waking up the brain and letting the brain understand what happened, and then just making it more aware of where the body's in space. The left brain and right brain are very different in that the right brain is typically the first brain to develop, and it develops a somatotopic map of not just the left side of the body, but also a little bit of the right side of the body. So with a right brain stroke, typically what you'll see is a hemi-neglect of the left side, and then with a left brain stroke, you'll see a hemi-neglect of the right side. But because the right brain was preserved in this case, I thought that he might still know a little bit about where the right part of the body was in space, if that makes sense to you guys. But he had no movement until we really started testing sensation and reflexes. So here's a video, and I'll just play it. All right. So we got Dex here playing barnyard pickup, and then he hasn't really moved his foot in a while, but after we provide some stimulation, we're getting a good withdrawal reflex, which he hasn't had, and he's able to flex his hip, and then dorsiflex his foot a little bit, and as you can see, bring it back down. So the more we vibrate, the more we're getting some stimulation, and yeah, that's the first time he's moved it in how long? Has he moved that? Do you know?
Since October.
Since October of 2017. So, good stuff. Okay, so in the video I say good stuff, but it's not good stuff because we're initiating a pain pathway. If you guys remember from the last lecture, allodynia refers to central pain sensitization, an increased response of neurons following normally non-painful stimulation, which most people think vibration feels good. That actually hurt his feet, but it's often repetitive stimulation. It can lead to the triggering of a pain response from stimuli which really don't normally provoke pain. Temperature or physical stimuli can provoke allodynia, which may feel like a burning sensation and often occurs after injury to a site, in this case the brain. Allodynia, again, just remember, it's different from hyperalgesia, which is an extreme exaggerated reaction to a stimulus which is normally painful. So if I was doing pinprick down there and he was like, whoa, then we'd call that hyperalgesia. But in this case, he has allodynia, because when I would put the vibration on his foot, he would basically, he'd give me a little scream and then tell me that it hurt, and it kind of felt like pins and needles. So what I did was I just utilized, before I really did anything else, I just started out with some light vibration in areas of the body that didn't hurt. I used some light touch with like a little brush, like a little paintbrush, just stroking the skin, as well as with my fingers, just kind of drawing different letters and numbers on his skin, seeing if he could recognize them, and just continuing to provide some of that light stimulation there. I utilize acupressure in different points on the right side of the body, acoustic frequencies, and with acoustic frequencies, a simple rule is the left brain likes beats, so songs and stuff like techno, and then the right brain really likes classical music. So what I would do is I would put some acoustic frequencies with good beats like techno music in his right ear to activate left brain to try to just lower that threshold of pain. And then of course we would do some adjustments. So I would do some joint mobilizations of his right hand, of his right toes, of his ankle, just to get some sensory input into the system so that the brain, one, knows where the body is in space, but also to just appreciate what used to be a normal, nice stimulation. So before I show you this video, I want to show you this one. So after 2 days, what I did was I would just do the stimulation and then I'd go back to the area and say, hey, how does this feel? And I could stay on there a lot longer without getting an exaggerated withdrawal reflex. He said it wouldn't bother him as much. So we just attenuated that area with consistent, repetitive stimulation. There's one, I hit a spot. But for the most part, he did really, really, really good with increased vibration. And then what was interesting was after I would do this, we would go through some light touch, some vibration, anything like that, and then I'd say, all right, now I want you to just close your eyes and visualize your foot moving, right? So some top down movement, and then this was after just 2 days.
Go ahead. Good job.
So again, I know it's a small movement, but it was huge for him. We always celebrate the small ones because he couldn't do that. That's more of a flexor synergistic movement. And again, with strokes, they're usually they are flexor dominant because your extensor tone comes with brain development, and when you lose that newer tone, or the newer brain, you start to just become more primitive, and that's why we go into flexor posturing. But flexor synergistic movement, but it's still movement. He was super excited about it. By the end of the week, he was dorsiflexing. He came in for a full week, and now he's coming in once or twice a week for a few weeks just to kind of follow up. But he's doing a lot of rehab at home. But the reason I wanted to show you this case was because we were able to basically afferentate different pathways using different types of receptor-based therapies to alter his perception of pain so that when I would touch with vibration, it wouldn't hurt. It would actually start to feel good. And that's a normal response. So we were able to basically downregulate that allodynia and make his brain better. And a better brain can modulate pain better. So it's that constant circle, that constant feedback. If your brain isn't healthy, if you have decreased functioning of brain, then you're going to have increased or heightened awareness of pain. So making his brain better altered his pain signals. So that's the end of the show. Kind of a short week with lecture. A lot of these overlap, but I just wanted to talk about why it's super duper important to understand pain pathways, but really how can we modulate patients' perceptions of pain doing receptor-based therapy like chiropractic adjustments, like vibration, like light touch, like acoustic frequencies or gentle air blowing on the ear, anything like that. Some pretty cool stuff, and you don't have to have any super duper special equipment to do it, and you can really, really help people. So thanks so much, and we'll talk next week.